Welcome everyone to the 11th annual Global Health Technologies Design Competition. My name is Ashley Taylor and I'm the Director of Education for Rice 360 Institute for Global Health. On behalf of our team, I want to express our gratitude to each of you for joining today to honor the work of some amazing student innovators. We would first like to thank our sponsors for the competition. This program is made possible in part by the Stephen W. Lay Family Endowment for Global Health and the Meta Family Foundation. Thank you so much for your generous support. We also want to express our sincere gratitude to all of our student teams, faculty advisors, coaches, and judges who creatively adapted to the virtual format of the competition this year. We have been encouraged and inspired by this passionate community of resilient problem solvers who have continued to innovate towards impact in global health despite difficult challenges this year. We thank you for joining today as we honor and celebrate the work of these amazing undergraduate student leaders. In just a moment, we will hear from our top 3 finalist teams, but before we move to our team presentations, I want to briefly share some of the hard work by all teams, coaches, and judges leading up to this special day. This year, we had a record number of applicants, and from this competitive pool, 33 semifinalist teams were selected. Semifinalist teams represent 23 institutions from 6 countries, including Malawi, Nigeria, Tanzania, Uganda, Ghana, and the United States. We also want to thank our 25 design coaches who mentor teams to support their work not only in the competition, but beyond as well. We are also grateful to our panel of 58 judges with a diverse range of expertise in global health who reviewed semifinalist videos and provided constructive feedback to each team to support their ongoing work. We also have an esteemed panel of judges joining today to select our first, second, and third place for the competition. And what we have seen across the entire competition is really an amazing community of passionate problem solvers coming together. We've seen a fierce commitment to working towards health equity for everyone everywhere. As Team Low Costonomy from Duke University shared, teams are invested in these design challenges. And we are deeply grateful to everyone who has invested time, energy, and passion into this year's competition. So lastly, we want to provide some guidelines for the competition today. First, in order to preserve bandwidth for the call, we ask everyone to turn off their video and microphone unless they are speaking. And if you are speaking, we of course remind you to please turn on your video and microphone as you are able. We will play each team video, and following each team will have 6 minutes to answer questions from the audience. Please place your questions in the chat or use the raise hand feature on Zoom, and we will call on you to ask your question directly to the team. And following all 3 finalist presentations, we will invite our judges to virtually vote for first, second, and third place, and we will talk about our ballot system at the conclusion of the presentations. And now, without further ado, we are so excited to introduce the people we all came to hear from, our finalist teams. Up first is the finalist presentation by Team Patho ML from Rutgers University in New Jersey in the US.
We are Kyle Lee, Kyle Manny, Joseph Wynn, and Megan Maniar from Rutgers University. Under Dr. Mark Pierce, we have developed Patho ML, which uses machine learning for breast cancer pathology in Botswana.
In every country across the world, cancer is a leading cause of mortality. For women, breast cancer is the leading cause of cancer death, and more than half of breast cancer deaths occur in low and middle income countries. In low-resource settings, patients do not receive a timely cancer diagnosis due to a lack of pathologists available to analyze tissue biopsies. This can result in a significant turnaround time between patient biopsy collection and pathologist diagnosis, causing delayed treatment and poor patient outcomes. In Botswana specifically, there is only 1 pathologist for every 500,000 people compared to a 1 to 18,000 pathologist-to-patient ratio in North America. This problem has been addressed through both outsourcing pathology services to other countries in Africa and the installation of complex digital slide scanners. Though these approaches allow for effective diagnosis, they are extremely costly, require additional training, and can keep patients in Botswana from receiving a diagnosis for weeks or even months.
Instead, our point-of-care tool, Patho ML, is low in cost and allows for a rapid diagnosis in just minutes without the additional demands of outsourcing, increased staff numbers, or complex imaging systems. It can be sustainably implemented in Botswana with infrastructure that is present in most major hospitals, including cell phones, microscopes, and networking capabilities.
To use Patho ML, a technician prepares a pathology slide of a breast tissue biopsy sample by traditional H&E staining. Using an attachment device, the technician mounts a cell phone to a standard microscope and takes a photo of the slide with a cell phone. Using an application, the images are uploaded to a machine learning algorithm. This algorithm classifies each image as benign or malignant based on image patterns common to cancerous or non-cancerous tissue. Once the images are classified, the technician is alerted of the diagnosis through the application.
With Patho ML, we have been able to classify pathology tissue images from a database of 9,100 images as benign or malignant with a 96% accuracy, and further subclassifying their tumor subtypes with an 80% accuracy.
While the dataset we've trained on is large and diverse, it is limited in that it includes images acquired from one source. In order to verify our high accuracy results for new images, we will have to expand our image dataset to include different sources. Since our prototype is being developed in collaboration with the Rutgers Global Health Institute and the Sir Kudamili Macaria Teaching Hospital, we plan to send it to Botswana for clinical implementation testing. With the feedback from our partners, we'll be able to expand our technology to other low-resource settings to improve healthcare delivery globally. Additionally, Patho ML can be applied to any type of cancer and other pathological diseases, making it versatile and broadly applicable. Thank you for your time and consideration.
Hello, my name is Yvette Marable. I'm the Executive Director. My video, so you can see me. My name is Yvette Marable. I'm the Executive Director of RISE 360, and I'm delighted to moderate questions for our teams today. We will now open up the floor for questions for Team Patho ML. Feel free to put questions in the chat or raise your hand if you have a question to share. While we wait for people to submit questions, I have one that has been pre-submitted by the judges. What are the sensitivity and specificity requirements for your solution to be successful?
Yep, I can answer that. For most diagnostic tests for within the medical field, a suitable sensitivity would be anywhere above 90%. Sensitivity for our project is at 98.2% and specificity is at 94.4%, making this a really good diagnostic tool in and of itself. However, we're aiming to improve this to have sensitivity and specificity values of over 95%.
Thank you. And we have a question in the chat. Is Patho ML able to stage the cancers?
I can take that question. So right now it is currently not able to stage the cancers, and based on our research, we think that that's something that pathologists would have to continue to be responsible for. But the beauty of our technology is that it doesn't act as a replacement for a pathologist. It just acts as a tool to make their work more efficient. So really, a pathologist can use this tool to maybe review all cases that come back as malignant or something like that, so that way they can be used in conjunction, speed up the turnaround time, and lead to a better outcome.
Thank you. The next question from the audience. What machine learning algorithm gave the 96% accuracy?
Sure, yeah, I could take that one. Yeah, that's a great question. So for our purposes, we used a convolutional neural network. So we actually use an existing neural network architecture of VG16, and using a bunch of like existing Python libraries and functions and things like that, we were able to train our algorithm using a large data set that we used online.
Let's see. Another question for the audience. Thank you for the great presentation. Which mobile phone models will work for this application? The camera is different in each model.
Hi, I can take that question. So yeah, we actually tested a wide variety of mobile phones for this application. And we specifically use the iPhone 4S, which was developed about 9 years ago, just to show that even with low, maybe not the best quality phones, the results will be accurate.
And a question shared privately. Has formative usability been conducted for the app? Are there important contextual factors that were considered during the design process?
I could take that. So right now our application is still in the building process. We're still kind of working out all the problems that might arise with it. But since we do have this partnership with the Rutgers Global Health Institute, we do have this direct line of communication with healthcare workers in Botswana. So we're planning to, put out surveys and ask them a lot of questions about the user interface as we continue to develop the application.
Let's see. Can you please repeat the number of images you trained the model on?
Yep, I can answer this question. So our model was trained using 6,000 images, and then we used 1,200 images to validate the testing and get our results, which is where specificity and sensitivity came from.
Let's see. Do you think machine learning algorithms can or will eventually replace most pathologists or even most physicians in the world?
I could take that. So I think machine learning is definitely a great tool in terms of what it can accomplish in the healthcare industry. However, I don't think the main purpose of it is really to kind of replace the role of pathologists, really to serve as an aid and kind of, in our case, to make an accurate diagnosis so that we can kind of reduce the amount of time that a pathologist would typically take to sort of make that diagnosis.
So I'm not watching the clock here. I think, how much time do we have?
Yes, we have time for 2 or 3 more questions.
Okay, excellent. So let's see. Is it possible to host a local server with the matching algorithm, or is this only available through cloud services?
Yeah, so currently our algorithm is kind of used like locally, using like a local area network or LAN. However, when we've been trying to develop this application that we plan on hosting on the cloud, so making it more readily available online. So that's something that we've been working on in terms of expanding it, to more people through a wider, area network.
And I'm gonna jump to the next related question. So, Jason Fu asks, I'm curious to know what are some limiting factors, if any, with this application, and how do you plan on overcoming it?
I can take this question. So I think the very first one is that we have a limited training and data set right now. It all comes from the same source. And ideally, we would like to, implement multiple different sources from low and middle income countries. The second thing is that, it might not be really practical to be implemented in regions where the hospital infrastructure does not already exist. And then third, it could be harmful in a case if if it provides false negatives or positives. And so that's where the whole, it needs to be more of an aid to the pathologist is going to be really necessary.
Speaking of pathologists, what is the sensitivity and specificity of a trained pathologist using standard equipment? And you gave some pretty impressive numbers for what you expect to be possible with Patho ML. So how does your device's performance compare to what's currently available to humans?
So based on a bunch of different studies, we know that human pathologists aren't 100% accurate in their diagnosis. And there's actually a lot of variety between a younger pathologist who's just come out of medical school versus an older pathologist who's been looking at slides for the past 20 years. So it is a little bit difficult to compare our results directly to a human pathologist. But since we do have that value of sensitivity and specificity over 90%, we know that that's a very good marker. And in addition, since this tool is supposed to be used in conjunction with the human pathologist, there are those backup checks in place.
Thank you so much, Team Patho ML. I think we'll move to the next team for the sake of time, and please feel free to respond to any questions directly in the chat that we maybe didn't get to in this portion. Thank you so much. Next up, we have Team Matone from Rice University in Texas in the US.
Over 500,000 children under the age of 5 die from dehydration-related illness every year, and this is particularly deadly in the global south. The WHO recommends IV fluid rehydration therapy for treatment, yet low-resource hospitals are often unable to use this with their pediatric patients. There are two major roadblocks to IV drip therapy in the global south: high cost and limited staffing. In Western nations, IV fluids are autonomously administered by electronic infusion pumps or elastomeric pumps, but with high price tags costing over thousands of dollars over each device's lifetime, they are oftentimes too expensive for low-resource hospitals. Thus, most low-resource hospitals have nurses constantly monitor child IV drips, as small volumes of excess fluid can mean life or death for the child. However, these hospitals are already oftentimes overworked or understaffed, and overworked nurses oftentimes risk giving a child too many IV fluids, risking a patient death. Thus, an ideal device to solve this in the global south would be something that is highly accurate, low cost, and can autonomously limit fluid delivered to the pediatric patient. To fill this need, we introduced Matone, a two-part, low-cost, easy-to-use device that aims to provide autonomous drain management of Western nations to the global south at a much lower price. With Matone, named after the Swahili word for drop, we hope to provide a low-cost and safe means of automatic IV rehydration therapy for children in low-resource hospitals.
Matone consists of two components, electromechanical controls and the shut-off mechanism. Shown here on the left, a healthcare professional can easily input the amount of IV fluid to be delivered to the child, and the device will automatically shut off once that amount of fluid is delivered. Underneath these buttons, the electromechanical controls hold an Arduino and strain gauge to continuously measure the weight of the child's IV bag, which is correlated with the IV fluid mass still in the bag. Shown here on the right, once that detected mass change has occurred, the shut-off mechanism shuts off the IV's flow, ensuring the patient has received adequate hydration. Here is a demo of our entire working prototype, set to shut off once 200 milliliters of fluid is delivered. With our device, once a nurse specifies the amount of fluid to be delivered to the patient, the nurse can freely leave to monitor other patients, ensuring that excess fluids won't be delivered. Here are the results of our accuracy tests. Doctors in low-resource clinics have specified that a shutoff error of less than 25 milliliters is ideal for a pediatric setting, which our device passes with flying colors. However, a limitation to our design is that the device currently only measures the volume of fluid delivered to the patient and not the flow rate or the time it takes to deliver those fluids. Yet, with the components to make Matone totaling below $70, and with its high accuracy and ease of use, we believe that Matone would be highly accessible and effective in low-resource hospitals.
Now, we believe Matone can also be used outside of treating children, and we think this device can act as a low-cost platform technology for various drain automation healthcare devices. Regardless, future clinical trials need to be run to assure the device's ease of use and hospital compatibility. Lastly, we hope to someday work with Rice 360 to advance our device's development and access in low-resource hospitals. Once more, we are Team Matone, and we thank you for your time.
We will now open up the floor for questions for Team Matone. Please again, remember to feel free to raise your hand or submit questions in the chat. We can get started with a pre-submitted question from our judges. Is there currently a way to control the rate of fluid delivery?
So right now, rate's not the problem. The quantity of fluid delivered was the problem. So that's the only thing the device can do right now, but it's a pretty simple step if we want to expand into the rate, because we've gotten a lot of questions regarding the rate of IV fluid drip, and that would just be a slight modification to the code, really.
This is as a follow-on to that, and Williams has submitted, don't you think the absence of flow rate is a setback?
So the doctors that requested this project didn't give any sort of flow rate specifications. The real problem they had, in particular for the doctors in Malawi that we were working with, the problem they had was just total volume overall. So I don't really think it's a setback at all. And if other doctors think that flow rate really is something important to look at, then that's a pretty easy implementation.
And a question from Joseph. Oh, sorry, that's your comment. So a question from Kathleen. Can you describe your implementation plan For example, will this device be fabricated, assembled locally? To what extent have you considered maintenance related issues?
So yeah, I can answer this. Essentially, our initial goals are to actually work, hopefully, with Rice 360 and use a lot of their implementation to actually get this out to low resource clinics, whether it be designed more locally and shipped out, or actually designed at these clinics is, future implementation steps we can do once we start working with a much larger org. But regardless, we have a very low assembly cost and actual low cost of materials only ranging below $70. So hopefully either way, we can just get these out to them.
And so from Elizabeth, this is an interesting technology. Thank you for your presentation. What are the other competitive products on the market? Can you please highlight the difference between your technology and Drip Assist, for example? And is the difference that you can shut off the flow mechanically, or are there other factors?
I'm sorry, I didn't hear the alternative.
Drip Assist.
Oh, okay. So I believe more Drip Assist related technologies use light sensors to actually count the drops manually that are going through the IV. There's, in terms of like infusion pumps or elastomeric pumps, typically all of these are at least ranging around thousands of dollars in terms of their device's lifetime. Whereas with our Matone, the only actual cost is the initial less than $70 and then potentially battery life costs. But yeah, so we range far below all of those price points. So we're much more affordable.
Question from Yusuf. If the device is mounted on the IV pole, will the measurement of weight be affected by movement or vibration in the IV pole? If so, how does your device deal with that?
So yeah, so if you move the tubes or move the pole and you tug on it, it will temporarily change, but just a little bit. And it sort of averages out over a second. So it just measures once every second. So vibrations are no problem. That gets averaged out.
Any question from Steve? Is there a way to detect if the IV line is blocked?
Yeah, so really this is just a fail-safe to aid the nurses. So the nurses are gonna still be continually going around checking these patients, hopefully. It's just more of a fail-safe.
Any more? So can you, from Elizabeth, can you please tell us more about your engagement with the stakeholders to identify the challenge and any feedback they've given on your concept?
Yeah, so this is actually a problem Rice 360 has been trying to tackle for about a decade. And so initially we actually heard about this project because I was in a Rice 360 Global Health Design class that used to talk about the MAGI IV drip project of about 10 years ago as a case study of a project that has still been out here, and they tried to develop a solution, but still needed to be tackled. So that's actually how we learned about it. We ended up reaching out to physicians in Queen Elizabeth Central Hospital in Malawi, in particular, just some of the head of the pediatrics ward there. And we ended up using a lot of the initial physician data and physician input for a lot of the error specifications we needed to achieve with our device, the cost specifications, and the usability scoring for our device. So we've been heavily Rice 360's initial work and then in addition to our consistent feedback with them since then, and we hope to continue the continuation of feedback with them.
We have time for one final question for Team Matone.
Okay, great. And we have one last one in the chat. What kind of prototype modifications do you anticipate you'll need to make before launching usability testing?
So it's almost ready. I think one of the big things is just labeling the buttons, because it was just for our use, really. We didn't label the buttons. So yeah, just like sort of easy things like that, simple things like that. But pretty much our prototype as is ready for ease of use testing. We actually have already tested it, just not in a clinical setting for ease of use.
I think we're at time.
Thank you so much, Team Matone, and please feel free to respond directly to questions and comments in the chat that we may not have answered during this time. And finally, we have Team Smart PVD from Macarrero University in Kampala, Uganda.
Hi everyone, I'm Pauline from Smart PVD team. Macarrero University, Uganda, and right here is my colleague Fiona. Our focus is to improve the accuracy of estimating post-delivery blood loss, hence early diagnosis of postpartum hemorrhage, commonly known as PPH. The number of expectant mothers in Uganda is rapidly rising compared to the number of midwives, to an extent that a single midwife in Mulago Hospital is likely to deliver between 5 to 8 mothers in a single shift, moving from mother to mother while taking their vitals and other physiological changes. Due to these overwhelming numbers, however, she's likely to miss some critical signs, and the results of this could be fatal. One midwife narrates of how she lost a mother due to bleeding complications that she underestimated because she was attending to 7 other mothers, and this woman joined the list of the 15 mothers who died daily due to birthing complications like PPH, and this could have been prevented with the accurate estimation of her blood loss, hence early intervention.
Current methods include visualization, use of soft gauze, and under-buttocks grips. These methods are inaccurate, tiresome, and are not suitable for the existing hospital settings, respectively. Therefore, the team is developing a smart PVD, a simple diagnostic device that will enable and allow midwives to quickly detect the onset of postpartum hemorrhage. The device is partially disposable, consisting of a blood collection module and a blood sensing module. The blood collection module ensures uniform collection of blood, and the blood sensing module ensures accurate measurement of blood collected in the pouch. Once blood is uniformly collected, the sensor probe detects the level of blood that corresponds to certain volumes, signaling the buzzer to alert. The buzzer will only give an alarm if the level of blood corresponds to the set volume, indicating an intending PPH case, which in our case is 400 milliliters of blood, close to 500 milliliters of blood, that defines postpartum hemorrhage by the World Health Organization. This will quickly alert a midwife of an intending PPH case, thus timely intervention and preventing life-threatening complications. The team is currently testing the prototype to improve on the accuracy of the sensor probe on a more specific volume. We've gotten feedback from the midwives from Mulago, and they have said that the device is easy to use and would provide much quicker results. However, they have also presented a challenge of positioning the device since the existing beds are not appropriate and suitable. Additional testing and prototyping will be done to fulfill the requirements of the preclinical evaluation ahead of the feasibility study at Mulago Hospital. And here is a video of the current prototype.
Thank you. We will now open up the floor for questions for Team Smart PVD. While we wait for questions to show up in the chat, or raise your hand if you prefer to just ask your question. We'll start with a pre-submitted question from the judges. Is there a way your device can be used once labor is complete?
Beg your pardon?
The question is there a way your device can be used once labor is complete?
Yes, our device can be used once labor is complete. Initially, we said it is partially disposable. So if maybe during labor, the device is used and then the collection module is taken away, and then we can get another collection module, and then you connect the blood sensing module, then it can be used immediately after labor.
Okay, question from, they're starting to fly in on the chat now. How do you ensure that the blood from the patient flows into your sensing module?
Pardon?
The question from the chat, how do you ensure that the blood from the patient flows into your sensing module?
All right, okay. The device is positioned correctly on the bed, and then also it is tied on the patient family. And then when you look at the design of the collection module, it has the aspect of directing the blood that flows directly to the collection module.
Now, how do you distinguish blood from other fluids of delivery?
All right. So when we looked at this, initially it proved a challenge, but since we've been working closely with these midwives, and then we've put this, that we've noted that the time on which we intend to place that device. So we are intending to place the device immediately after the baby is being born. So because when the baby is being born, that's when these other fluids come in. So after the baby is being born, and then we are targeting the delivering of the placenta. So that's where the rest of the blood comes in.
Question in the chat. Is your collection device custom made or fabricated from an existing device?
It is fabricated from an existing device, but we are modifying it to make the workflow of the clinicians better. The drape exists, but we are modifying it.
And then we are also using locally raw materials.
Okay.
Yes.
So can you share the current and projected unit costs for the device?
Currently, the existing costs for the current costs for the existing drip.
Yes, the current cost of the existing device and projected unit costs.
The current drip costs $6. Yes, alone.
Let's see. How does the sensor work? Does it detect capacitance, currents, or something else?
Okay, the sensor works on the principle of, so we are using resistance that is correlating with the volume of blood that is collected.
So even if the fluid touches the sensor before the volume has reached, it will not alarm unless the level of the blood has reached where it was programmed to sound.
And is the sensor a single use, for single use or multiple use? And how, if it is multiple use, how will it be cleaned between uses?
Actually, the sensor, I would not call it a sensor. The ones that you're seeing in the collection module, they're called probes. So the sensing bit is outside. So the probes are single use, and then this sensing module that it's outside. So we are working on the effective disinfecting principles as being used in health facilities. So this other bit, the sensing module, will be disinfected, like cleaned using
70% alcohol.
Thank you. And can you tell us more about your engagement process with midwives?
We've talked to several midwives from Mulago National Referral Hospital and from Kawempe National Referral Hospital. And then they've given us a feedback because we've been working closely with them and then the gynecologists to see that we get a minimum viable product that is really suitable for this cause. And then they've given us a feedback that there is a need for this device because honestly, it's alarming. And then they've given us a feedback that the device will provide quicker results, and then it is also accurate. We've also tested this prototype on expired blood, because the video we shared, we were testing it with water, and then we've also tested it with expired blood to still check on how this will effectively help the midwives. And then they've given us a go ahead.
And for one more question for Team Smart PVD.
Yeah.
Well, then I'll ask a question from Steve. So how do you account for the fact that blood will clot once in contact with the device? Does the device sense semi-solids?
Actually, during our designing process, we've accounted this by creating a delay on the blood that is flowing. So if we are creating a delay of like 10 seconds, and at least most of the blood will have flowed down.
Thank you so much, Team Smart PVD, and please feel free to respond to the questions in the chat that we may not have answered in this time together. Thank you so much. And at this time, we will now move to our brief break for our judges to submit their ballots. I will now turn to my colleague, Emily Macarrero, to explain a bit about the judging system. And here I would like to express deep gratitude to Emily for all of her leadership on this event. Many of you have been interacting with Emily quite frequently, and just huge thanks to her for her amazing work on this competition. Emily, over to you.
Well, thank you, Ashley. I very much appreciate that. Hi, everyone. My name is Emily Matero, after that wonderful introduction from Ashley. I also want to say a huge congratulations to all of our semifinalist teams before we move into judging. It's been such an honor to be able to watch your work and really support all of your endeavors through this competition. So now to our judges and our design judges and our design coaches who are on the call with us today. I am going to put this link to our judging ballots in the chat. So I'm going to send that over right now. Please click the link and submit your rankings for the top 3 teams. To everyone else who is just here to view and enjoy the presentations, feel free to take a quick stretch break and we'll be back in just a couple of minutes. And judges and coaches, if you have any questions about the ballots, please let us know.
Okay, I believe we are at our 2-minute judging break is wrapping up. So if you haven't voted yet, please be sure and do that quickly. And while that's wrapping up, I'd like to invite Dr. Santorino to turn on his video, and so people can see both of us as I give your introduction. So welcome back. Thank you to our judges for submitting your finalist reviews. It is now my pleasure to introduce our keynote speaker and present the 2021 RISE 360 Innovation and Leadership in Global Health Award. Throughout his career, Dr. Data Santorino has demonstrated an inspiring commitment to driving innovation and invention in global health. Dr. Santorino is currently the Uganda Country Manager for Camtech, Uganda, and is a pediatrician and lecturer at Mbabara University of Science and Technology, or MUST as we say more frequently. Dr. Santorino has championed the creation of an innovations ecosystem that includes the monthly MUST Innovation Cafe, an innovation office, a co-creation laboratory, and a students innovation internship program that targets medical technology development for low and middle income countries. His work with Camtech Uganda led to the establishment of the MUST Center for Innovation and Technology Transfer, CITT, that he currently leads as founding director. He is collaboratively involved in the development of the Augmented Infant Resuscitator, an add-on device to existing bag valve mask that monitors and provides instant feedback on resuscitation quality. He founded the Simulation for Life program that currently partners with medical and nursing training institutions to scale medical simulation technology methodologies in Africa. Dr. Santorino has a wealth of experience in research, teaching, innovation management, and program implementation. We deeply admire Dr. Santorino's leadership in crucial maternal and newborn health initiatives. And at RISE 360, we passionately share this social agenda with him. We are honored to present the 2021 RISE 360 Innovation and Leadership Award to Dr. Santorino. We award this accolade each year to those who best exemplify our Institute's dedication to innovation for global health. As a true global health visionary and pioneer, Dr. Santorino embodies the qualities we want to see in our students as future global health innovators. Dr. Santorino, thank you so much for joining us today, and over to you for your keynote address.
Thank you very much. I'm exceedingly honored and humbled to be awarded this accolade and be invited as a keynote speaker to this innovation event. For those who do not know much about me, I would like to share my story of survival, love, and circumstances that I believe built my character towards innovations. I was born in the uncertainties of Southern Sudan and survived in the jungles of the Congo. And in those uncertainties of Southern Sudan, when I was in exile, when my parents were in exile, a lot happened to us. I think one of my great survival moments was when my immediate follower got polio. And Basil, up to now, is wheelchair bound. And because of innovation and technology, innovation and science, today Basil is mobile. And I would like to thank especially the two great women at Rice University that I've exceedingly admired, Dr. Rebecca Kotum and Maria Odon, whose work in supporting innovations has been extraordinary. So I feel exceedingly humbled to have been invited to an event that you pioneered and lead. Now, to the team of innovators here, I'd like to share my story of curiosity. When we were growing up in the Sudan, we did not have the luxury of TV and the luxury of toys. We watch vehicles, we look at vehicles, and we started making our own toys. The most famous toys we were playing with were vehicles made out of tin and metal seats, and we will stitch these metal seats together to become the shape of a vehicle, put on tires, and we will run around with them. One time, I was a little bit frustrated by the look of these wire-stitched vehicles. And as an 8-year-old that time, I started thinking of ways of how we could be able to use tin and create vehicles without wire stitching, because finding wire was difficult and we were mainly using electricity wires. That meant destroying somebody's electrical system sometimes. So as an 8-year-old, we stretched out a metal seat, creatively cut it, folded it, and we were able to design a sedan that really did not need any metal stitching. And I thought that was good. When war broke out in the south in Sudan, we had to move back to our mother country, Uganda. And the education system took us. When I reached university, in my final year of medical school, preparing for the final exams were really cumbersome. It was a lot of mental work, and I needed a break from the mental work. So much time was needed for reading. And as a student who was not in the government halls, I wanted to minimize the time I'll spend cooking lunch. So as part of my time, my free time away from reading, I went to the orthopedic workshop and started designing an oven that will be able to cook food just using the direct sun. I'll read during the day. In the evening, I'll do metal work and woodwork. And I designed this box that in the scorching time, we will just open it up, put our rice and our meat in it, and 2 hours later, we had lunch. The physics department was interested, and they wanted to formally test this solar oven. And during the testing, it acquired internal temperatures of up to 170 degrees and burnt. That was in medical school. When I joined postgraduate, we had multiple challenges, and I was inspired both with my passion to solve problems and my itchy hands. And the rest was history, and we started a movement. And this movement gave birth to what we called Camtech Uganda in 2020. 2011. The movement started in 2011 and it became Camtech Uganda in 2012. I was given a blank check by Massachusetts General Hospital and said, you have interest in innovation in a university that traditionally does not innovate. What will you do? So I told the director of the Center of Global Health at Mass General that if we are to grow innovations, I think the first thing we need to do is to be able to find a forum for us to discuss problems. Because when we discuss problems a lot, they become challenges. And when we brand them as challenges, our minds open up to think about the solutions. But if we brand challenges as problems, the terminology problem will limit our minds and we will not think about solutions. So then the Camtech Uganda Innovation Ecosystem was born with this flagship program of innovation cafes. We started meeting monthly, initially with staff members of the university and later with students, to just complain about the problems that we were experiencing or they were experiencing in healthcare. The more we talked about these problems, the more people started thinking creatively about them. And the more solutions started. And what I learned from this process is that our minds are great. But whatever we tell our minds determine how much our minds unlock or how much our minds become inhibited. Currently in our innovation ecosystem, we dread using the word problems because of its inhibitory effect and encourage people to use the word challenges instead. For we believe when you address problems as challenges, your mind opens up to possibilities. When we started that, we learned something interesting, and that was related mainly to the Ugandan culture. In Uganda, we are largely verbal. Many people talk a lot, but they write little. What we quickly learned was that students were quick to think about a challenge and a solution and go to prototype it, but they did not want writing it about it. So we designed our innovation pathway in such a way that immediately after discussing about the problem, the next stage you go is the innovation support office, where you will be tasked to use existing literature and write a concept that defines your challenge, the potential solution, and how that solution is the best fit for this problem. Many innovators ran away from this writing rigor, but those that remained were a great success. And we noticed that our concepts were really great building blocks to attract funding that will be able to fund the innovation process. So as of now, Camtech Uganda has existed for about 8 years. We have had several students go through. As of now, up to 30 of these students that have gone through, most of them are employed within Camtech Uganda with their own startups. They have attracted funding, they leverage the leadership of staff in the university and have continued developing their own technologies with their own funding that they have attracted. One important principle I would like to share with our innovation ecosystem is that when you are part of our innovation ecosystem, we desist from being the judges. Because we believe when teams win, they need to celebrate and learn. When they fail, they need to learn. And that is the mental model that I learned the hard way. And I will encourage all the innovators of today to have that principle. That in every competition, there must only be two outcomes: to win and learn, and if you fail, you must learn. And because of that, we don't judge how our teams progress. We bring independent people to do that, so that when they fail, we can cry with them and learn together. When they succeed, we can celebrate with them and learn together. And my appeal to all the mentors of today's teams is that let this not be the end of engagement to today's teams. Irrespective of what happens to them, let's embrace them. Let's embrace their success and make them learn from it. And for those that are not successful, let's embrace their failure and let them learn from it. Our world is great, but we can make it greater. And it's upon you and me to be the solutions to the problems that this world has. And for us to be able to be the solutions to these problems, we cannot work alone. We need to work with partnerships, with partners. I thank you so much. Thank you for the honor. The most important thing is that, one, bridges exist because we need to work in partnership, and partnerships bring success. I thank you.
Thank you so much, Dr. Santorino, and it's a pleasure and an honor to have you here with us today. We do have time for questions from the audience. So please join me in thanking Dr. Santorino, and whether you want to raise a question in the chat or raise your hand and be called on to ask your question directly. That's either way is fine. A chance to raise questions. While we're waiting for others to raise questions, I might ask, I think right now globally we're all been overtaken by COVID-19 and the impacts on our countries. And I'd be curious to hear about any ways in which Camtech or CT, any of the efforts out of MUST that you've led have responded or been able to respond to the challenge, and mostly because they exist, and how the existence of that capacity that you've built has really allowed your institution to contribute to solutions right now during this global pandemic.
Thank you so much. So when the COVID pandemic hit Uganda, and we are just 2 weeks into the lockdown, we had a great crisis. And that great crisis was for hand sanitizer for users. there was a total scarcity of hand sanitizers. But there was a team in our innovation lab that had been actually certified to produce hand sanitizers 2 years ago, but their capacity was very small and there was no market, no much market for their hand sanitizer because in Uganda, the culture of using hand sanitizers was not there. So the first reaction we did was we converted our innovation lab into a hand sanitizer production factory. And all projects in the innovation lab went to a standstill, and we were producing hand sanitizer 24 hours a day. There were long lines waiting of businessmen and individuals waiting for hand sanitizers, and people were booking batches that were under production. And we did rudimentary methods to try and meet demand and argued to the government to think about how local initiatives like that can be able to survive. And as I talk now, the government has funded us to automate, to buy a production line and automate and increase our production of hand sanitizers. And I think that was our response to the COVID pandemic.
And I see a question in the chat from Elizabeth. What advice would you have for medical device developers who want to design using human-centered design best practices, but where there are many more barriers to visiting healthcare settings and directly observing the challenges that are currently faced?
I think what I'll tell people is that you just need to talk about the problem. Generally, human beings are very useful. They are more useful than harmless. And it's human culture to try to support. So I think the bridge is communication. Whenever you need to go to a clinical care setting, talk to the clinicians, talk to someone who holds the key to it. And trust me, most of the time, you will have the do's and don'ts and they will let you in. That's my experience. So communicate and ask the right people.
Wonderful. Any other questions? Don't be shy. I'm being told I'm getting audio problems, so I might switch over to Ashley.
Sure. Dr. Santorino, thank you so much for your powerful and call to us keynote address. Thank you. What other questions, comments do we have for Dr. Santorino? Well, if there are no other questions or comments at this time, we will again express our sincere gratitude to Dr. Santorino for joining us today. It's such an honor to have you here and to hear more about your work and your story. So thank you again. And let's take a moment to perhaps unmute yourself or use the virtual applause and let's show our gratitude to Dr. Santorino. Thank you.
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 Thank you. That was wonderful.
Thank you.
So at this time, it is our joy to present our awards for the competition for 2021. We have everything tallied, and a thank you again to our esteemed panel of judges for being here today to help evaluate our finalist presentations. We would first like to announce our People's Choice Award. And this year I want to highlight, we launched a virtual People's Choice Award. If you have not had the opportunity yet to view the amazing teams videos across our semifinalist teams who elected to participate in the People's Choice Award, please do visit our website. These will remain posted for some time, though voting is closed. So we encourage you to view those and again, honor the work of the student innovators. And a huge thank you here to Nicole Moreno and Emily Mataro for leading this work. Amazing, amazing, amazing vision to help share the work of the student teams. We are pleased to share we had over 4,700 votes in this year's People's Choice Award. And we are very pleased to announce that this year's winner of the People's Choice Award is Team Mavid from Dar es Salaam Institute of Technology with over 800 votes. I believe we had Team Mavid on the call a moment ago. And if Team Mavid, if you are still with us, we would love to hear any thoughts you'd like to share about the competition and maybe what you're excited about in your project moving forward.
Hi, hello.
Yes, hi, we can hear you.
My name is Joel from Team Mavid. My friend could not join us today. First of all, thank you for this competition, and we are really excited to this, and we would love to thank Rise and DIT, mostly the community, for trusting us and accept us in our project. So the best challenge we had is how it was the first time in this big competition for both People's Choice Award and other competition. So we learned a lot on how to create things and how to present things in a different perspective. So really happy for that, and we say thank you, and thank you so much for that.
Well, thank you so much, Team Mavid, and we reflect that gratitude right back to you. Thank you for your amazing engagement in the competition and for your amazing work in global health innovation. And congratulations again on being the 2021 winner of the People's Choice Award. Next, we will announce our third place winner. And in third place, we have Team Matone from Rice University. Team Matone, would you like to share some thoughts about the competition and maybe what you're excited about in your project moving forward?
Yeah, so thank you so much. We had an amazing time developing our device despite the COVID-19 pandemic. We hopefully look forward to working with Rice 360 to get our device implemented in actual real hospital environments.
Thank you so much, Team Matone, and congratulations. In second place, we have Team Smart PVD from Macarrero University in Kampala, Uganda. Team Smart PVD, we'd love to hear your thoughts on the competition and what you're excited about as you move forward in your project.
Hi everyone, yeah, very grateful that we were granted this opportunity to take part in this competition, and we look forward to getting more partners to work with, as well as funders, and also mentorship for financial and technical aspects of our project. Yes.
Thank you very much.
Yes,
yeah. Honored, yeah.
Congratulations, Team Smart PVD, and thank you so much for your amazing engagement and brilliant work in global health innovation. And our first place winner is Team Patho ML from Rutgers University. Team Patho ML, we'd love to hear from you. Congratulations, and any thoughts on your engagement in the competition and what you're excited about as you move forward in your innovation work.
Wow, thank you so much. We're so excited to accept this award. And on behalf of my team, I just want to say thank you so much to everyone involved in this process. The Rice 360 team, the judges, the coaches have been immensely helpful to us. And we're so excited to begin incorporating their feedback into our project as we move forward.
Thank you so much, Team Patho ML, and congratulations again. And at this time, this concludes our competition. I do have just one note, a suggestion from one of our judges I would like to share with this amazing community. If you would like to connect with one of our finalist teams to provide additional feedback for their work or mentoring, please email me and I would love to help connect you to have those conversations as we continue onward. And we want to again express our gratitude to all of our student teams and coaches and judges who engage in the competition. And once again, thank you to our sponsors, the Stephen W. Lay Family Endowment for Global Health and the Meta Family Foundation. Thank you again for your generous support. Dr. Santorino gave us a powerful call when he said we can transform problems into challenges. Our world is great, but we can make it better. And to do that, we cannot work alone. We must work in partnership. And so to this amazing community, we say onward and forward in this incredible work towards equity and global health. Thank you so much for joining today and take care.
Thank you so much.
Thank you.
Thank you.
Thank you. Bye-bye.
Thank you.
Thank you all.
Thank you.
Congratulations, everyone.
Thank you all.